Hello, my name is Valeria Santini. I work in Florence at the hospital Careggi, and I am responsible for the MDS unit. So my task is to take care of MDS patients and elderly AML. Today, I would like to point out how we manage patients who fail treatment with hypomethylating agents. And first of all, I want to stress the fact that HMA failure has to be evaluated after the patient has received proper treatment. That means the optimal schedule and standard dose, and a number of cycles that should be at least 6. So after 6 cycles, if the patient has not experienced any response, we may actually think and define the patient as a primary resistant patient to hypomethylating agents. Whereas 60%, around 60% of patients with MDS, high-risk MDS, will respond to hypomethylating agents. And I want to remind you that in Europe, we use only, and we allow to use only azacitidine. So if the patient responds to azacitidine, and then after a number of cycles that could be more than 6 or less than 6, but then progressing, even if she has maintained for a long time this response and then relapse, then this is the secondary or adaptive resistance. Why do I point this out? Because these two mechanisms of resistance are probably different, although we don't know yet what are the exact mechanisms leading to resistance. Having said that, the patients who lose response or never achieve response to hypomethylating agents has to be reevaluated completely. This means that not only we perform cytogenetics and a bone marrow aspiration, of course, but also we should repeat NGS determination of somatic mutation. This is because during the history of the disease, we may experience the appearance of additional somatic mutation, and some of them could be targetable with the agents we have, even if the agents are still experimental, but we could address the patient in an experimental trial. And actually, what is true is that at this point, we do not have many experimental trials for patients relapsing or refractory to a hypomethylating agent. So what can we do? The last 2 studies with guadecitabine and rigosertib. So guadecitabine is a long-acting decitabine that is coupled with deoxyguanosine, and this should allow a longer exposure and less deamination of the compound. This study had the comparison of guadecitabine to best supportive care or low-dose RC or 3+7 regimen in a randomized fashion in patients who were refractory to treatment with hypomethylating agents. Now, unfortunately, the study has not shown an increase and an advantage in overall survival. And unfortunately, the same result was true for rigosertib, another interesting drug that was given in the same setting of patients and had as a mechanism of action the inhibition of polokinase and kinases in general. So we are left with not many options, but what I want to stress is that there are many new drugs coming, now explored in de novo MDS and showing indeed a good activity. So we have a different range and different types of drugs and agents that I will discuss. The first one is indeed venetoclax. And as a matter of fact, venetoclax has been used in addition to azacitidine in patients who had lost response to hypomethylating agents. And this addition led to 41% overall response rate in relapsed refractory patients. Not only, but if the patient could pursue 6 cycles of treatment, the overall response rate was extremely higher, was 83%. These are the data presented by Amer Zeidan and indicating an overall survival longer than 1 year in the patients who responded. So AZA plus venetoclax, despite the fact that we have to carefully follow the patients because of myelosuppression, seems to be an optimal combination to rescue patients who lost response to hypomethylating agent. So this is one option, but there are other options that, as I mentioned, unfortunately are not available for patients in relapse or refractory. These are, for instance, the addition of magrolimab is an anti-CD47 antibody that has the capability to, let's say, eliminate the do not eat message, so the CD47 presence on leukemic cells, and enhance macrophage phagocytosis of leukemic cells. So this drug has shown an extremely high efficacy in de novo high-risk MDS, even in patients who presented with TP53 mutation. Same is true for other drugs like pevonedistat in a complete different mechanism of action. And pevonedistat is an agent that is inhibiting methylation and is increasing, therefore, the elimination of leukemic cells, and has shown very high activity in high-risk MDS, and is probably going to be approved very soon. There are no data at present and no studies indicating that the possibility to treat patients relapsed refractory with pevonedistat, but that could be a way to go. Finally, there is another, let's say, immunological approach to high-risk MDS. That is the treatment with sabatolimab. That is an anti-TIM3 antibody that is attacking TIM3, that is an antigen expressed both on leukemic cells and immune cells, and it could be enhancing immune reaction towards leukemic and dysplastic hematopoietic stem cells. Once again, these drugs and these studies are only for de novo MDS, but there has been shown a bit of some activity of sabatolimab single drug in relapsed refractory settings. So as a matter of fact, we are facing many new drugs, but we also have specifically targeting agents like ivosidenib and enasidenib. Ivosidenib has been shown to be active in the patients with relapsed refractory MDS carrying mutation of IDH1. And although the number of patients treated is quite an interesting approach, as well as the approach with enasidenib in patients who lost response to azacitidine. A study of 2 arms with de novo and refractory relapsed patients with high-risk MDS showed that indeed around 50% of the patients treated with enasidenib can have a very good response to the treatment with single drug, if they, of course, carry mutation in IDH2 gene. So these are 2 target agents that could be very useful and are approved in AML, and could be very useful also in high-risk MDS after loss of response to HMAs. Finally, there is another interesting drug that is APR-246, that is an agent that restore the function of p53 in patients who have mutation of TP53. Now, this drug has been evaluated in a couple of studies, one in by Dr. Salman and another by Dr. Clouseau in the States and in France, and has shown indeed a great activity in patients mutated with p53. Once again, the ones who have the worst prognosis. But these are patients de novo. And the idea would be to treat patients also after HMA failures. So we have a range of possibilities still to evaluate and apply to refractory patients or relapsed patients. I really hope that in the future, by good characterization of the patients, we will have many agents available to treat them. One thing I have to stress, even if it's an old message, is that the patients have to receive proper, optimal schedule and dose of azacitidine or other hypomethylating agents, because if we stop too early, the patients will lose response. If you do not treat with the schedule and the standard dose, we may give a suboptimal therapy that is leading to resistance. And therefore, these are the first recommendations. Just keep the patients on treatment until progression, treat with regular interval, and follow up the patients carefully. And in case of relapse or refractoriness, just reevaluate completely with MGS in order to find the best treatment and possibly targeted treatment for them. Thank you.